second consensus criteria for diagnosis of MSA. And you should also be able to diagnose patients with MSA using the novel MDS criteria for diagnosis of MSA. So the presentation is split into two halves, as we heard before. Iva Stankovic starting with the critique of the second consensus criteria, and that will be followed by my presentation of the new MDS criteria. So Iva, go ahead.
Thanks. I would like first to thank to the organizers for inviting me to present in this webinar, and also to the participants for their interest in this topic. I will talk today, as mentioned, about the shortcomings of the second consensus criteria for the diagnosis of multiple system atrophy. Autonomic failure, Parkinsonism, and ataxia are core clinical features of multiple system atrophy, and selective striatonigral and olivopontocerebellar neuronal loss and atrophy in these systems underlie the division into two motor phenotypes of MSA Parkinsonian and MSA cerebellar type. The second consensus criteria consider 3 levels of diagnostic accuracy, including definite MSA. This diagnosis is made on autopsy, and 2 clinical categories of probable and possible MSA. These clinical categories are actually based on a combination of features suggestive of autonomic failure, Parkinsonism, and cerebellar syndrome in any combination. In the Gilman criteria, there is a list of supporting features. These are MSA red flags, actually clinical features supportive of MSA diagnosis. And also there is a list of non-supporting features that are not very common in MSA. Diagnostic tests feature in the Gilman criteria only as additional features of possible MSA, and these are atrophy on MRI of putamen and posterior fossa structures, including middle cerebellar peduncle pons and cerebellum, and also hypometabolism on FDG PET in the same areas. And for MSAC, another additional feature is presynaptic nigrostriatal dopaminergic denervation on PET or SPECT. This lady presented at the age of 79 years with irregular tremor, slowness, features suggestive of REM sleep behavior disorder, and repeated falls. MRI was normal in her case, and she has beneficial levodopa response. And when we performed the bedside standing test, we realized that already in the supine position, her blood pressure was low. And after 3 minutes of standing, she complained about symptoms called in the literature sometimes like a coat hanger pain, and now she has syncope. In the orthostatic position, her blood pressure was extremely low, as presented here. Next patient is 2 years into his disease course, and you can see that he presents with a bit slower and broad-based gait, but not really much more than that. And then after 1.5 years, he develops a very severe gait impairment requiring help of another person. He is very unstable and has postural instability, which I would like to highlight here as a very distinctive clinical feature in early disease stages of MSA versus Parkinson's disease. And also, this video was about to present to you that MSA is really a rapidly progressive disease. and these patients usually, many patients become wheelchair bound within 5 years from onset, and this is therefore marked as a red flag against diagnosis of Parkinson's disease, and also in the literature this is called the wheelchair sign. And finally, this is a patient with a cerebellar syndrome. He started to complain about dysarthria, speech impairment, unsteady gait, and also he had increased snoring. He had emotional incontinence, which is a red flag, actually supportive feature of MSA diagnosis. You can see bradykinesia bilaterally and also ataxia. And hyperreflexia as well. Although the second consensus criteria were widely used for the past 14 years as the diagnostic gold standard for MSA diagnosis, validation study of this criteria revealed that they have poor accuracy, poor sensitivity at early disease stages, which ranges from 80% for probable MSA to 41% to possible MSA at first neurological visit. Also, two large clinical pathological studies from the Queen Square Brain Bank and Mayo Clinic Brain Bank with patients clinically diagnosed with MSA showed that patients clinically diagnosed with MSA only have this diagnosis in 62 to 79% of cases, suggesting suboptimal diagnostic accuracy. Therefore, the Movement Disorder Society study group on MSA tried to identify issues related to the poor accuracy of the suboptimal accuracy of the second consensus criteria, and we will discuss these issues now. Later, the task force within the Movement Disorder Society was established to drive the revision process and to develop the new criteria. So the Gilman criteria require post-mortem diagnosis, require post-mortem examination for the definite diagnosis, and this is obviously impossible, not possible while patient is still alive, and therefore there is we identified the need of a category term clinically established MSA, which would be category with maximum specificity at the expense of sensitivity during lifetime. The second category would be clinically probable MSA with balanced sensitivity and specificity. And finally, we identified the need of for possible prodromal MSA category, which would require follow-up. And this category with diagnosed patients with predominant non-motor symptoms, such as autonomic failure and REM sleep behavior disorder, and only mild motor signs that would then during follow-up develop full-blown clinical presentation, but also this category should have satisfactory specificity. Next issue is clinical heterogeneity. We now know from and have enough data from these studies that that some patients with pure autonomic failure during several years develop a synucleinopathy with central involvement. This is either Parkinson's disease or MSA, and 8 to 28% of these patients actually phenoconvert to MSA. In addition, risk factors for the phenoconversion of pure autonomic failure to MSA have been identified, and these are normal olfaction, subtle motor signs, age of onset in early 50s, supine norepinephrine level greater than 100 picograms per milliliter, preganglionic pattern of sweat loss, heart rate greater than 70 beats per minute in the supine position, and orthostatic heart rate increase greater than 10 beats per minute within 3 minutes of standing. In the past decade, patients with disease onset earlier than usual have been highlighted and observed, and these patients have onset within 30 and 40 years, between 30 and 40 years of age. This is a patient who complained at onset about slowness in the right limbs, dizziness, and urge incontinence. On acute levodopa challenge test, he experienced some side effects such as vomiting and orthostatic hypotension, but still small doses were introduced, and he has transient beneficial response lasting for a couple of years. And then you can see that he had very severe bladder impairment with retention that required catheterization, also orthostatic hypotension and typical MSA signs on MRI. Further investigation showed that he had incomplete cardiac noradrenergic denervation on MIBG SPECT, and the pattern of striatal, pontine, and cerebellar hypometabolism of FDG PET. Colleagues from the Queen Square conducted this very nice study with young onset MSA patients, and when these patients were compared to the patients from the European MSA study, it was shown that this patient had better levodopa response, more dopa-induced dyskinesia, more frequent dystonia, and brisk reflexes. But when these patients were, which is a more realistic situation in the clinic, when these patients were compared to patients with young onset PD, it was shown that young onset MSA patients had more autonomic features, more frequent myoclonic tremor, they had more frequent orofacial dyskinesia, pyramidal signs, and limb ataxia, while patients with young onset PD had better levodopa response, more dopa-induced dyskinesia, and interestingly, only young onset PD patients had off-period food dystonia. Next phenotype is long duration MSA. These patients usually start with the motor symptoms, usually Parkinsonism as described in the literature, and then they develop autonomic failure after mean 11 years from symptom onset. These patients had moderate levodopa responsiveness and frequent levodopa-induced dyskinesia, and this is the reason why actually moderate L-DOPA responsiveness and frequent L-DOPA-induced dyskinesia are the reason why these 5 patients described in the study of Vasilius Meissner and colleagues were subjected to the deep brain stimulation that unfortunately was not beneficial in this case. Finally, it has been recognized that also MSA patients have cognitive impairment, which is most frequently in the form of mild cognitive impairment, while dementia and hallucinations are rare. The study by Koga and co-workers has revealed that greater burden of neuronal cytoplasmic inclusions in the dentate nucleus is associated with cognitive impairment in MSA. Response to levodopa is a very important issue because 2 natural history studies from Europe and the US showed that substantial number of patients have a good levodopa response at early stages, which is usually waning after 2 or 3 years. And moving on to genetic factors. So in terms of enrollment in clinical trials and clinical practice, MSA is a sporadic disease. It's considered as a sporadic disease, but in the research setting, MSA is results from the continuum of genetic, complex trait, and sporadic factors. There are many MSA lookalikes, genetic disorders, which we decided to somehow group for easier orientation into disorders predominantly presenting with ataxia and Parkinsonism and spastic gait, autonomic failure, and complex phenotypes. And also not only genetic disorders, but also autoimmune mediated disorders associated with antibodies are recently reported to mimic MSA. The list of these disorders you can see on the left side on the slide, and the reason why they are mixed sometimes with MSA are overlapping features between disorders, and these are most commonly rapid progression, ataxia and nystagmus, autonomic failure, and REM sleep behavior disorder. And also on MRI, these disorders may have hot cross band sign and cerebellar atrophy, similarly to patients with MSA. Non-supporting features of MSA diagnosis could be replaced by exclusion features that would be ideally core features of MSA-related disorders, such as Parkinson's disease, PSP, and corticobasal degeneration that are unusual for MSA. I mentioned the diagnostic tests were additional tools of possible MSA in the Gilman criteria, and in order to really see the utility of a number of diagnostic tools that were used in patients with MSA, the MODIMSA study group performed these two large systematic literature reviews. One focused autonomic function test and imaging and how they contribute to the early diagnosis of MSA, and the other focused other diagnostic tools and their usefulness in the diagnosis of MSA. Diffusion-weighted imaging is a very useful tool for differential diagnosis of MSA and Parkinson's disease. In meta-analysis, it was reported that increased diffusivity of putamen has sensitivity and specificity greater than 90% for distinguishing MSA from Parkinson's disease. And also, if increased diffusivity in middle cerebellar peduncle would be added to an algorithm in the automated analysis, accuracy of this method is again greater than 90%. Automated subcortical volume segmentation was shown to have a very good accuracy, almost 100% in early disease stages, to distinguish Parkinson's disease from MSA and PSP, and this is based on volumes of midbrain cerebellar gray matter and putamen. When a patient has orthostatic hypotension, the first question is whether it is neurogenic or non-neurogenic, and this ratio of change of heart rate and systolic blood pressure upon standing within 3 minutes, validated with a head-up tilt test and also active standing, is accurate for diagnosing neurogenic orthostatic hypotension. And when it comes to again, I mean, when we know that the hypertension is neurogenic, then the question is whether for how long this should be, the orthostatic position should last, and what would be the cutoff for the orthostatic hypotension. And actually, if the time of blood pressure measurement would be extended to 10 minutes, and a cutoff for orthostatic hypotension set at 10 millimeters of mercury. Additional 18% of MSA patients would be correctly diagnosed according to this European multi-center study. Autonomic function tests are useful and the gold standard to diagnose autonomic failure, but they are not useful for the diagnosis of MSA in particular. From this test, I would like to highlight bladder sonography, which is easily accessible in routine clinical practice and probably provides very good information about post-void residual volume, which is, although more studies are needed, already according to data that we have at the moment, already increased in patients with MSA compared to patients with Parkinson's disease in the first years from symptom onset. Dr. Singer and colleagues have published this nice study recently showing that detection of alpha-synuclein oligomers in the CSF and increase concentration of neurofilament light chain in the CSF can distinguish patients with MSA from patients with Lewy body disease with almost 100% sensitivity and specificity. Finally, I would just like to touch upon the skin biopsy. Detection of phosphorylated alpha-synuclein in skin fibers is useful, can be useful for differential diagnosis between MSA and Parkinson's disease with orthostatic hypotension. Deposits of phosphorylated alpha-synuclein are in majority of patients with MSA found in the somatic fibers of subependymal plexus, while in Parkinson's disease, these are located in the postganglionic autonomic fibers. This is another recent development in terms of diagnostic tests for diagnosis of MSA. Laryngeal dysfunction during endoscopic task assessment has been shown in one study to be almost 100% accurate for the diagnosis of MSA versus Parkinson's disease. Actually, in this study, 43% of patients had clinically overt laryngeal dysfunction, but when these patients were examined on endoscopy, almost all of them showed signs of laryngeal dysfunction. And among these findings, irregular involuntary movements of the erythronoid cartilages had this 100% specificity and more than 90% sensitivity. Multi-center study is now recruiting patients. And with this, I would like to thank you for your attention and would hand over to Gregor to present the MDS criteria for the diagnosis of MSA.
Okay, Eva, thank you very much for this very nice presentation. So my task now is to present the new criteria commissioned by the Movement Disorder Society for diagnosis of MSA. Can I have the next one? This task force was chaired by myself and Horatio Kaufmann. There were a number of members and external expert consultants, as you could see here. Next. The methodology of the criteria revision was evidence-based. A systematic literature review was performed. Questions on clinical and presentation and diagnostic tools that were relevant were identified. Next. And we achieved consensus based by a process that included 2 Delphi rounds with a certain number of questions and also a survey of the entire MDS membership. And it was concluded by a final virtual consensus conference. So just to illustrate to you the sort of new developments in the MDS criteria, we still have a category of neuropathologically established MSA. It's now differently phrased. but you still need neuropathology to diagnose definitively MSA. Then we have the category of clinically established MSA, as suggested in the critique, just to allow clinicians to confront patients with a clinically definite diagnosis. We keep clinically probable MSA with the more balanced sensitivity and specificity cutoff, and a new category of possible prodromal MSA to capture the very early stages of the disease has been introduced. Next. So essentially required is a sporadic progressive adult onset over age of 30 years onset disease. This slide illustrates to clinically established versus clinically probable MSA. So if we start with clinically established MSA, this is probably the most important slide of my entire presentation. The core clinical features include at least or include autonomic dysfunction with at least one of those three features listed here: voiding difficulties with the post-void residual of greater than 100 milliliters, urinary urge incontinence, not explained by other causes, and neurogenic OH defined as greater than 20/10 millimeter mercury blood pressure drop within 3 minutes of standing or head up tilt. So at least one of those three features needs to be present. And then there are a number of supportive clinical features, could be either motor or non-motor. I will present those later on. These are sort of red flags for MSA, and you need to have at least two of those. And then there is a list of MRI markers associated with MSA, and you need to have at least one of those. I will present those later on. And then there is a list of exclusion criteria that need to be absent. The division into MSA P or C according to the predominant motor syndrome is kept as it was the case in the revised consensus criteria. Clinically probable MSA is slightly different. You need to have either autonomic dysfunction, any one of, can we go back one? No? Okay, keep it like this, Eva. At least two of autonomic dysfunction, Parkinsonism, or a cerebellar syndrome with at least one feature of cerebellar involvement. There needs to be at least one supportive clinical feature, either motor or non-motor. MRI markers are not necessarily required, so it can be a purely clinical diagnosis, and exclusion criteria need to be absent. We excluded erectile dysfunction as an isolated feature because it is pretty non-specific. Next slide. The autonomic features include, as before, voiding difficulties with the post-void residual volume, but the cutoff here is not specified, could also be less than 100 milliliters. There is a kind of natural history of the post-void residual, and it can start less than 100 based on the literature review. We keep urinary urge incontinence. Neurogenic OH includes both classic type within 3 minutes, but it can extend up to 10 minutes in terms of delayed neurogenic OH, which can also satisfy this criteria on autonomic dysfunction. Okay, so if we now look at some of the supportive motor red flags, clinical motor features, this includes craniocervical dystonia, as we can nicely see here in this lady, in the absence of levodopa-induced limb dyskinesias. The second motor feature is jerky myoclonic postural tremor or kinetic tremor, as seen here. It's also touch sensitive, and a range of postural deformities that are shown here. Anticolis, this is the PISA sign or PISA syndrome, and this is contractures here of the fingers and hands. Other motor red flags include rapid progression within 3 years of motor onset, moderate to severe postural instability within 3 years of motor onset, severe speech impairment within 3 years of motor onset, severe dysphagia within 3 years of motor onset. All of this is judged by the clinician expert, basically, and unexplained Babinski signs. Next slide, please. These are some of the supportive non-motor features. This includes stridor. This is a lady coming in to the room, and you can easily appreciate this very striking noise she's producing, inspiratory stridor. There is also inspiratory sighs. It's a kind of respiratory myoclonus. Maybe we can repeat that once more. It's difficult to appreciate. Now, just very briefly, a deep sigh, basically, and then cold discolored hands and feet due to denervation of the vasculature, sympathetic denervation, and further signs or symptoms, erectile dysfunction below age of 60, and pathologic laughter or crying. Next. This is now the list of MRI markers. Each affected brain region, as evidenced either by atrophy or increased diffusivity, counts as one MRI marker, and it's divided kind of into MSA-P and MSA-C. These are the atrophy signs. So atrophy of the putamen associated typically with a reduction on iron-sensitive sequences, atrophy of the MCP and the pons, and the cerebellum in Parkinsonian type MSA, very suggestive. The hot cross band sign is more common in MSA-C, but it can also occur in MSA-P, and it's pretty characteristic. Diffusivity in the putamen, we already heard about this in the critique paper, and increased diffusivity of the MCP in Parkinsonian type MSA. So these are all the MRI markers, and you would need one of those for clinically established MSA. Next, sorry, go back again. This is showing you the putamenal atrophy, the hyperintense rim sign, hypointensity of the putamen in dorsolateral, pontine and cerebellar atrophy, nicely illustrated here. Atrophy and hyperintensity of the MCP in the T2 weighted images, and then diffusivity increase in the posterior putamen as shown here. This can be readily quantified. Next slide. This is a list of exclusion criteria. So essentially, these are meant to discriminate MSA from Parkinson's disease, dementia with Lewy bodies, and PSP. For the sake of time, I won't go through all of those now, but you can see here which of these items refer to exclude which of the other differential diagnoses. Next slide. Now, this is one case showing you MSA-P. This patient started off with urinary retention following prosthetic surgery and erectile dysfunction, followed by urge incontinence, so kind of urogenital presentation of MSA, then followed by Parkinsonism, poor response to levodopa, and falls. So this is a kind of clinically established MSA-P case. Next slide. Bladder sonography showed an increased post-void residual volume of 210, and MRI showed a rim sign here bilaterally, and also increased diffusivity in the putamen posteriorly. Well, this should have been now a kind of exercise for you, but I already gave the diagnosis. I think we can skip this. Next slide, please.
I will just let for 20 seconds and then I will show
Okay.
the results because we
Okay.
have it already.
I'm sorry that was not intended that I gave you the diagnosis, but anyway. I think that the result is pretty clear, clinically established MSAP. This case was very straightforward. Next slide. Okay. So this is a summary of this case. Again, urogenital dysfunction plus Parkinsonism, 3 supportive motor features, 2 MRI markers, lack of exclusion criteria. So all of that indicates clinically established MSAP. Next. Now we come perhaps to one of the major innovations here in the MDS MSA criteria. And these are the criteria for possible prodromal MSA. And basically, there are 3 distinctive ways, non-motor ways to enter into MSA. One could be isolated REM sleep behavior disorder, PSG proven. The other one could be neurogenic OH with a significant blood pressure drop upon within 10 minutes of standing or head up tilt, or urogenital failure with erectile dysfunction starting less than 60 years plus voiding difficulties and a post-void residual of 100 milliliters plus minus urinary urge incontinence. So these are the 3 non-motor ways to enter the pathway of MSA, plus subtle Parkinsonian signs or subtle cerebellar signs, not consistent with a full presentation, but with a very minimal or mild presentation. But without these motor subtle signs, the task force decided it will be impossible to be sure about these 3 presentations here entering into the MSA pathway. So this is why they are included. The exclusion criteria include unexplained anosmia, which is inconsistent with MSA, or an abnormal cardiac MRBG scintigraphy, which is supportive of Parkinson's disease. Clinical features suggestive of DLB and PSP, an alternative diagnosis based on brain MRI, and documentation of MSA lookalike conditions are exclusion criteria also. Next slide. So this is a patient here, 63 years, starting with dizziness and blurred vision when standing up. So, and after climbing stairs since 58 years of age, so 5 years before. And the husband reported RBD-like phenomena during sleep, talking and moving around during sleeping, an increase in voiding frequency and a need to press on her abdomen to empty the bladder. So some urological involvement as well. This here shows you the tilt table test result with a dramatic drop of blood pressure. Now we can show the slide, the video.
In his garden, and I kept getting dizzy. Which meant stand up, I would go, ooh, and I just have to sit down repeatedly. You could almost picture the blood going from my head down to my feet. I would feel like the room was spinning.
So these are the orthostatic complaints the patient reports.
Dark, like sort of tunnel vision. And then my hearing would go very, like cotton was in my ears. All of a sudden you hear again, and it's quite dramatic.
So we here see the supine blood pressure, 149/97.
The bladder, I would say, was first. Dizziness and lightheadedness.
And this is the tilt.
Probably was almost around the same time as the sleep disturbance. So I just figured, well.
So you could see the major drop of blood pressure down to 108, 97 here. And the diastolic blood pressure was also decreased.
Started with a urologist, and he.
So basically, this is altogether a very suggestive combination of orthostatic hypotension plus RBD phenomena during sleep. And this cutoff here, or the ratio that Eva mentioned before, is less than 0.5, suggesting neurogenic OH. So this is the classic combination. Polysomnography was done and RBD was detected. UPSID to look for olfactory function was also performed, showing normosmia. The post-void residual volume was 141 milliliters, so substantially increased. Parkinsonian signs were also present. We can see that in the video, but very subtle, not justifying or satisfying MDS PD diagnostic criteria for Parkinsonism.
Doing it fast.
We can just see a very mild pattern of bradykinesia, slightly reduced arm swing here.
Keep going, open, wider.
You can see that here also. Amplitude getting a little smaller, a little irregular, a little slow, but it's all very modest. So now, what is the diagnosis in this patient? We have clinically probable MSA-C, possible prodromal MSA, clinically established MSA-P, and clinically probable MSA-P.
Okay, 10 seconds to go, and I will show the results.
Okay. We'll be all eager to learn what the result is here now.
And here are they.
Okay, I think the vast majority of people concluded that this satisfies the criteria for possible prodromal MSA, 77% of cases. Some thought that this could be clinically probable MSA-P, but as we discussed before when looking at the video, the Parkinsonian signs were not of a magnitude justifying the PD criteria for Parkinsonism, so that doesn't apply. And cerebellar ataxia was not really evident in this patient, no nystagmus and no ataxia in the limb. So all three entry criteria, mild Parkinsonian signs, lack of exclusion criteria, altogether make up this possible prodromal MSA. This is at the very early stages of MSA, and it will be important to follow up and validate these criteria further prospectively. So this is 2 years later. And you can see clearly the progression of the Parkinsonian state here. The arm swing bilaterally reduced, short step gait, broad-based, and here bradykinesia in both hands with repetitive movements left more than right.
Okay, now make a fist.
So basically, she is now
And open again as fast.
developing more manifest MSA. This is the acute levodopa challenge test, which Eva, can I ask you to report this slide? I'm not so familiar with that one.
So this slide is really just showing that her reduction was in the UPDRS motor examination was less than 30%, which means that the levodopa response was not really beneficial.
Okay. So that's clearly demonstrating now lacking levodopa response. Next slide. This is another follow-up video.
Fingers as big.
Very rapid progression now, it seems. Gait very unsteady, almost a tendency to fall. Bradykinesia getting more severe on the left side.
Make a fist. Start going down the hallway.
This is very nice to see the progression of the Parkinsonian state over a pretty short period of time that you would never see in Parkinson's disease. So that's a red flag by itself.
Okay,
so here you can see now, another 6 months later, she is sitting in her armchair. Mobility is more impaired even. And on this side here, MRI showing you the rim sign here, hypointensity in the posterior dorsolateral putamen. This also shows you the iron deposits here on that sequence. And you can kind of almost appreciate the beginnings of a hot cross band sign in the vertical plane. There is a natural history of the hot cross band sign as well. It usually starts here vertically, and then the horizontal hyperintensity comes later. There's also cerebellar atrophy. So what is your diagnosis now? We need to wait another few seconds. Clinically probable MSA-C, possible prodromal, clinically established MSA-P, or clinically probable MSA-P. We just wait now.
So 40% have already voted, just a few seconds more, and then I will show the results. Here are they.
Okay, now we have a full house of MSA. So Parkinsonism, very rapidly progressive. That by itself is a red flag. Kind of wheelchair sign almost, sitting in the armchair. Association with with a non-beneficial levodopa response, autonomic features, all of that suggestive, plus the MRI changes of clinically established MSA-P. So if we go through that again, autonomic dysfunction, yes. Parkinsonism, clearly present, 4 supportive motor features, 3 MRI markers, lack of exclusion criteria. So all of this makes MSA-P kind of established. And the point really is that at this level, it is quite meaningless to label this probable MSA. The patients start wondering, what do I have? Is it just probable? They would like to know what they have. And at this stage, we therefore decided for this terminology, clinically established MSA-P. Next. Now we come to the supportive biomarkers for clinically established and clinically probable MSA. They are not part formally of the criteria, only MRI is, because the clinical evidence from the multiple studies that have been done is not 100% convincing. These findings need to be validated in future prospective studies of trying to validate the criteria, but it includes FDG PET. Hypometabolism has been reported in the putamen, brainstem, cerebellum. In MSA-P, in MSA-C, putaminal hypometabolism has been described. MIBG scintigraphy is usually normal, but not always. Up to 30% of MSA patients can have a denervation pattern. RBD needs to be PSG proven. It's pretty closely or tightly associated with MSA, but obviously it's more likely because just of the prevalence difference to develop into Parkinson's disease rather than MSA. Supine plasma norepinephrine levels greater than 100 picogram per milliliter associated with neurogenic OH suggest MSA rather than Lewy body disease. Urodynamic testing, detrusor hyperactivity with impaired contraction or detrusor sphincter dyssynergia are typical patterns seen on urodynamic studies. An abnormal sphincter EMG and more recent data suggests that PMCA or RT-QuIC of alpha-synuclein oligomers shows their presence in CSF, and there's a suggestion that these oligomers have different conformations compared to Lewy body disorders. NFL, neurofilament light chain on ELISA is also increased in CSF or plasma in many cases. But all of these data, as mentioned before, need to be validated in a prospective study. Now, these are supportive biomarkers for possible prodromal MSA. MRI, we suggest atrophy of the putamen and signal decrease on iron-sensitive sequences, atrophy of MCP, pons and cerebellum, the hot cross band sign, and increased diffusivity on MRI of putamen and MCP. FDG PET, again, hypometabolism of putamen, brainstem, and cerebellum. Supine plasma norepinephrine greater than 100 picogram per milliliter associated with neurogenic OH, suggesting a preganglionic pattern of pathology. Urodynamic testing, as mentioned before, for clinically probable or established MSA. Sphincter EMG is abnormal or should be abnormal to suggest MSA development. Alpha-synuclein oligomers and NFL is the same as mentioned before. So whether these, go back again, sorry, whether these features are really all of them equally important or not to predict MSA in a possible prodromal pattern of the disease remains to be determined in future studies. Next slide. So the key conclusions at this stage are that the MDS MSA criteria are meant or designed for clinical practice, inclusion of patients in clinical trials and research studies. MODIMSA, the movement disorder MSA study group, is conducting a prospective multicenter validation study of these MDS MSA criteria. It's ongoing work. We will need 1 or 2 years to come up with a solution here. The MDS MSA criteria will clearly need revision as time goes on, with data from ongoing and future studies becoming available. I think that's the last slide, and I would like to thank you for your attention. I would like to thank the European Reference Network for inviting us here to present this work together with Iva Stankovic. And we are now ready to take questions if there are any.
Yes, okay. Thank you, Gregor. Thank you, Eva. Thank you very much for this very clear presentation. With regard to the wish of the speakers, we will take up questions first regarding the first part. So please write your questions in the Q&A box if you have any for addressing the part that Eva presented, and then we will take up questions regarding the part that Gregor presented. So we have already 2 of them. I will start reading the first one. How do you distinguish between MSA and an autoimmune lookalike?
Okay, thanks, Sanja, for this question. I mean, for reading this question. Okay, so well, actually, this is really something that is really new in the literature, and it was only published in January this year. Considering there are overlapping features between these disorders, one would need to do some additional investigation in a patient that the clinician suspects could have autoimmune mediated disorder. These include lumbar puncture and analysis of CSF for the oligoclonal bands for protein and cell count. So this is sometimes oligoclonal bands are sometimes present, and the other features in the CSF could be increased in these disorders, but not in MSA. Then MRI could be distinctive because of the specific findings associated with these autoimmune mediated disorders that are not present in MSA. Of course, there are some overlapping findings, and as I mentioned, but there are some other that could be helpful. For example, affection of limbic system and so on. And also, one should look at the clinical features. So, because these autoimmune disorders really present with many different features, and some of them are not specific for MSA. So one could look at that as well. And I think that EEG is also helpful. I mean, it's normal in MSA, but could be abnormal in other diseases. And I think that rapid progression, I mean, at least in my experience, is more rapid in these autoimmune disorders than in MSA.
Mm-hmm. Right. Then the next question, how much genetic testing do you do in the workup in order to exclude MSA mimics?
So am I supposed to answer to this?
Well, yeah. It's not really indicated to who of you, Laura, has asked this question. Maybe, Laura, you can specify. If not, you can tell in your own centers. How do you do?
Yeah, it's the question relates to the MSAC, right? Or let me have a look. Okay. So this is, I mean, genetic testing is much more important, obviously, for the differential diagnosis of MSAC. We usually, I mean, at least in Belgrade, we perform genetic testing in patients who start earlier. So maybe you notice that in this case with young onset MSA, we also perform some genetic testing of Parkinson for the genes that are implicated in the pathophysiology of Parkinson's disease. But also for MSAC, it's a really important differential diagnosis. So one is to consider this if a patient is younger. Two is if there is a positive family history. So this is like obligatory, and we usually do the most frequent mutations in at least in our population, and these are SCA 1, 2, 3. And then SCA7, Friedreich ataxia, and Fragile X syndrome. So this is most commonly done.
Mm-hmm. I would fully agree with that. Yeah, it's mainly related to the question of MSAC being, possibly by differential a genetic disorder.
Mm-hmm. Thank you. The next question, are there any biomarkers or risk factors that are good candidates to predict time to phenoconversion in prodromal MSA patients?
I think if I answer that, I think that we don't have any good data really to predict the time of phenoconversion. Obviously, MSA is a much more aggressive disease, and we saw that in this one case with very subtle Parkinsonian features at the beginning. I think you need to look for this type of motor involvement repeatedly, and it would probably also help if you have video recordings so you can compare that to earlier periods. But there is this very rapid evolution of Parkinsonism or ataxia that you do see in these MSA patients. In terms of other biomarkers, some of them are mentioned in the supportive or biomarker biomarkers that can be helpful. One of them, for example, the level of norepinephrine in plasma greater than 100 picogram per milliliter, which suggests a preganglionic pattern of pathology in the sympathetic pathway present in MSA, but not in Lewy body disorders like Parkinson's disease or dementia with Lewy bodies. That's one possible factor. Eva, you want to add something to this?
No, that's, I mean, I agree.
Okay.
Basically, we need to do a full-blown validation study to determine those markers. Obviously, it is of great interest also for drug trials that we are able to predict these factors.
Sorry, actually, if I can add, is that there is this paper published by the group from Mayo Clinic last year showing that patients with who phenoconvert to MSA with pure autonomic failure, that they already have these alpha-synuclein oligomers present. I mean, this is just to make a note.
Yeah.
Mm-hmm. Thank you. Another one, we have recently had several patients diagnosed at very early ages, 30 years of age. So is this a possible outlier of the normal 50 years onset?
I think in the literature, the earliest case that I'm aware of started at age 30. Before that, I'm not really aware of postmortem confirmed cases. It's obviously a kind of category that has been labeled young onset MSA, YOMSA, with a slightly different phenotype, with higher levels of DOPA responsiveness, dyskinesia development, dystonia. These patients are often mixed up, or virtually always mixed up, with Parkinson's disease in the early stages. And I think that the development of autonomic failure is the most important clue in these patients to watch out for. So if there is any doubt, that there may be some motor red flags present in these patients with orofacial dystonia or myoclonus in the fingers, jerky tremor, and so on, I think that this is the time to investigate these patients further with MRI, looking for the MSA changes, but also autonomic testing that can then maybe reveal a normal innervation, sympathetic innervation of the heart, and so forth. But, primarily it's a clinical approach, looking for the core features and looking for supportive features.
Mm-hmm. Thank you. And then there are two questions related to treatment with levodopa. So the first one, how to deal with the partial response to levodopa? Stop if side effects appear, or stop due to insufficient response? And the second one is, should someone who develops cervical dystonia within a week or two of starting levodopa keep taking it?
Well, I think this is an important issue. We know that there is striatal degeneration that develops in these MSA patients that stops them from responding very well to levodopa clinically. And one sign of striatal disease, in my view, is the development of this orofacial or cervical dystonia, sometimes also of limb dystonia. And this basically indicates that it requires a very careful judgment of benefit or harm to the patient. If there is no benefit at all, bradykinesia, rigidity, and so on, not improving, and there are side effects like orofacial or cervical dystonia that can be disabling, I think that's the case for tapering off levodopa and maybe just eliminating it completely from the drug chart. So this is basically what I would like to answer to this question. Eva, maybe you have something to add here?
No, I mean, if there is, for example, a cervical dystonia, one could consider applying botulinum toxin for treatment. So this could be helpful.
Okay, and there are two questions from the same participant. The first one is, Dr. Wenning, do you suggest COG10 in early MSA? And the second question is, how long can you have the autonomic features before the movement or motor system start?
Well, the COG10 is interesting. It goes back to the discovery of Japanese investigators of COG2 mutations. COG2 is involved in the making of COG10, and it's important in the mitochondrial chain. So if you have dysfunctional COG10 or reduced levels of COG10, there is going to be oxidative stress. And it's interesting that in Japan, cerebellar phenotype is more common. Purkinje cells are very sensitive to oxidative stress, so there may be a link here. And that's why the Japanese started a large phase 2 trial of COG10 in sporadic MSAC, actually, not familial MSAC, but sporadic MSAC, to determine whether COG10 is able to slow down the disease process. Data of that trial have not been reported, but the study has been completed. And unless we have those data, there is no real evidence to support the use of COG10 in MSA. So I would wait before these results become available from the Japanese study. And then the second question about autonomic features becoming evident before the motor involvement starts. I think my first natural history study that I did in London and published in 1994 showed that 50% of the patients start with autonomic features, either NOH or urogenital dysfunction, and the other half starts with motor symptoms, ataxia, gait ataxia, or Parkinsonism. So that is, in terms of the time, it really depends. Classic MSA, I would say autonomic features can go on like 5 years maybe before the motor symptoms start. But we heard before that there is this new category of long duration MSA where autonomic failure starts 10 years after motor onset. These patients are often or mostly diagnosed Parkinson's disease because the time course is kind of similar. But once the autonomic failure kicks in, there is a very aggressive progression in these patients, at least in my personal experience.
Thank you. And would a levodopa infusion pump be beneficial for MSAP patient?
That's a very interesting issue as well. This has never been studied. There are no data on a continuous levodopa delivery in MSAP. I mean, this could be well explored. It's a shame, in my view, that this has never been studied. There is no evidence, with the lack of the studies that would need to be done. There's no firm evidence in favor of levodopa infusion pumps, unless this trial is done, basically.
Thank you. And another one also concerning levodopa. What is the maximal posology of levodopa that can we prescribe for MSA patients?
Okay, that is actually defined already in the Gilman or consensus criteria paper. Basically, we would suggest that if necessary, in terms of the severity of Parkinsonism, and tolerated also in terms of not aggravating NOH too much or not causing dizzy spells or other orthostatic complaints or sickness or so. If it's tolerated, levodopa should be titrated slowly up to a maximum of 1,000 milligrams over 4 weeks. So it's basically a chronic levodopa challenge test. If you do see an improvement, in other words, 30% or more reduction in the MDS UPDRS motor score, we would classify that as a responder, meriting further levodopa treatment in this patient.
Mm-hmm. Thank you. When do you expect to start recruiting for the prospective study to validate the new criteria?
We are still working on the protocol right now. It hasn't started. I think it will probably start after the summer break.
Mm-hmm. And the last question would be, is there more detailed information on the mimicking conditions? Could alcohol-related brain damage be one of them? Is there any research related to this and MSA?
I mean, if you consider the genetic mimics that Eva presented in her slides, then there are probably close to 50 now that might produce an MSA mimic. So there are many of these mutations that can give rise to autonomic failure, Parkinson's, ataxia in various combinations. I think the key issue here is to look out for specific features associated with these mutations. So there may be, cutaneous changes in some of these mutations. The best thing is to look this all up in that table published in the critique paper in the Movement Disorder Journal. There you find this nice summary of all the genetic lookalikes. Alcohol, in my view, does not cause anything similar to MSA. It may cause a chronic ataxic problem, but in my view, there is no strong evidence of autonomic failure in alcoholism or so basically I would not accept alcohol as a cause of MSA.
Mm-hmm. Okay, so thank you very much. Thank you for presenting this and for answering all these questions. You see that there is a lot of interest by the audience in this topic. So thank you also to the participants for actively being involved in this webinar. And our next webinar will be on brain development in Huntington's disease on the 8th of March. So you can register if you're interested in that topic through our website. So I wish you all a nice evening and see you soon. Thank you and bye-bye.
Thank you.
Thanks.
Bye.
Thank you. Thanks, Eva.